Thank you. We want to thank Medicine X Conference for providing us an opportunity to share with you a project that's very special to both of us. We have both been working on joining forces for probably the last 5+ years. We also view this project as a model for improving the health care of populations for which there's a disparity of care compared to the general population. So we will cover and talk to you about the Joining Forces, an overview of the Joining Forces project, as well as Joining Forces Wellness Week. And we'll provide perspectives from the patient, from the educator, from the trainee, and also from the assessor. And we'll have plenty of time for questions and hopefully some answers. And then we'll provide you a summary of our perspectives and lessons learned. We have 4 learning objectives today. One is that participants will be able to understand the 3 key elements in the evolution of this national initiative and consider implications for closing this gap in the practice of medicine and also in medical education. And 3 ways collaboration can address a healthcare gap. And additionally, consider this as a model to address other gaps.
So my job today is to let you know a little bit about the Joining Forces program that was just finished by the Obama and Biden administration. It's been a national initiative that provides support to the military connected, and their aims were really to improve the health, wellness, education, and employment opportunities for those with military connections. We joined the initiative at the Association of American Medical Colleges about 5 years ago now, and marshaled 100 of our medical schools to participate in the initiative. So by January 2012, we had our schools volunteering their missions toward the aims of the initiative. Once we launched the initiative with the White House, we stepped back and took an assessment of the environment and thought through, okay, what do we really know? What's our baseline effort here related to the initiative? What's going on at medical schools for the signature injuries of the current wars, which are PTS and TBI, for instance? So several staff at the association undertook a survey where we looked at these important health issues. We found gaps, and the biggest gap, though, was that military service was not being seen as an aspect of patient diversity, and very little was being done to educate students, residents, current physicians related to caregivers and family member health needs related to their service as a military family. So we saw an opportunity to improve medical education for these important health issues. Steve will now take you through some compelling information for why this initiative has been so important.
I'll provide you some sort of facts on why this initiative is so important. There are currently 1.5 million servicemen and servicewomen in the military, as well as an additional 1.4 million reservists who could be deployed at any time. Since 9/11, there have been 2 million military that have been deployed to Afghanistan and Iraq. About 40% of all service members actually will be deployed more than once. Additionally, the deployments can last anywhere from 6 to 15 months. There's also about 10% of the U.S. population over the age of 18 that have served or are serving in the military. Now, why do men and women in the United States actually serve in the services? There's multiple reasons often given. Patriotism, sometimes family tradition, to develop self-discipline. Sometimes it's to learn a new skill or trade, and for some it's, a steady income with benefits. So of those who serve in the military, when they return to the United States, many of them have multiple health issues. These medical issues are often common to the general population, but often will have an atypical presentation, or they may be rare in the general population. About 1 in 3 service men and women show signs of combat stress and are diagnosed oftentimes with major depressive disorder or PTSD, post-traumatic stress disorder. 15% of U.S. infantry experience PTSD post-deployment. Of those with PTSD that seek medical care, 53% of those who screen positive, only 53% actually receive treatment. Now, there's also an additional 15% of women in the U.S. services who suffer military-related sexual trauma. Additionally, we have about 250,000 veterans or servicemen and women who have TBI, traumatic brain injury. 5 to 15% of those will be complicated by PTSD as well. Between 2012 and 2005 and 2010, about every 36 hours, a serviceman or woman committed suicide. And in 2012, we had 20 to 25 veterans who committed suicide every day. I guess there's some good news in that with targeted behavioral therapy, the rate of suicide has decreased dramatically. Okay, yeah.
So, along with these compelling health issues, another great reason for our community to step up to the plate was the academic affiliations. VAs and academic medical centers have had a 70-year history now of working together to provide care for veterans. And so through this affiliation, many things occur. 22,000 of our students train every year at a VA, 37,000 residents train every year at a VA, and interact with this patient population. So while patients may receive a lot of care at the VA, once a person leaves the service, they may use the VA, but many will not, however. This means that there are over 22 million veterans in our communities who may just look like the rest of us. Once out of uniform, they really don't look any differently than us. And so they are in our towns and cities and neighborhoods seeking care just like us. But it's important for providers to be aware of the military connected and their nuanced health needs. This slide offers several implications for providers. The bottom line here is that by the nature of their military affiliation, health needs are different than those of civilians. Being educated as a provider will help you provide better care to these folks. To address all that we've just described, our association started an education campaign called Joining Forces Wellness Week. When we saw those gaps in the survey, we felt compelled to do something. So, intentionally coinciding with Veterans Day, we've offered a 5-day webinar series where each day offers a different topic related to military health needs. This program has been the cornerstone of our effort, along with local things that our schools have done on their own. Joining Forces Wellness Week was a way to raise awareness of these unique health issues of those who have served and provide education to our community about these concerns. From the beginning, several values guided the development of our webinar series. First was including interdisciplinary perspectives and approaches. We also wanted to offer a program specifically for our schools and institutions, but we permitted anyone to attend. That whole everyone included really spoke to us. Ensuring we had topics that covered family and caregivers was a high priority for us because that was definitely a gap in our survey work. And then viewing military service and connectedness as an aspect of patient diversity was really foundational for us. What we saw was that our schools were teaching these important health issues, but they just weren't including the military patient perspective. The first year we offered the webinar, we were pleased. 100 people joined us over the course of the week. And we were excited about that because we just didn't know what our participation would be like. After 2 years of sponsorship, we ran into some logistical issues and reached out to the White House, and they helped us build the program out. And so that's when the Center for Deployment Psychology at the Uniformed Services University of Health Sciences became our technical partner. And then other education associations like us became our communication partners. So it was a groundswell of effort and collaboration from the beginning. Through the years, we've covered a variety of topics through a variety of perspectives. We've had everyone from physicians to chaplains to nurses, nurse practitioners, you name it, they've probably taught in our course. We've covered so many different things, but what we know is that there's still a lot of work to do. And at this point, I would like to offer a patient perspective to you to maybe compel you even further about why this is so important beyond the numbers and information we've provided. As a Marine Corps officer, Justin Constantine volunteered for deployment to Iraq in 2006 as a civil affairs team leader. While out on patrol, and it was a routine patrol actually, he was shot in the head by a sniper. Amazingly, Justin survived, and we just want to share his story with you today. This video was produced for one of our Wellness Week sessions last year, and Justin has gladly granted us permission to share it with you today.
Hello, and welcome to Joining Forces Wellness Week 2016, and today's webinar, Pain Management, Nuances for the Military and Veteran Patient Population. My name is Justin Constantine, and I served in the Marines from 1997 to 2013. It's been 10 years since I was injured. At first, I faced significant pain due to the extent of my injuries and was on morphine while in the hospital. I continued to take Percocet after each of my surgeries, but I made it a point to stop taking the painkillers as soon as reasonably possible. I've had a wide variety of healthcare providers, ranging from those in the military, public, and university hospitals. The level of care has ranged from not very good in some cases to incredible in others. In 2006, I was deployed to Iraq, and while out on patrol, I was shot in the head by a sniper. I'm only here because of an incredible Navy corpsman who saved my life on the front lines. In fact, when George first rolled me over, I was no longer breathing. But he was able to keep me alive and then raced me to the aid station where I received immediate medical care. Then I was quickly sent to a military hospital in Germany and then on to Walter Reed Bethesda Naval Hospital for 6 weeks. There, the doctors were not sure I was going to survive. At one point, my fever spiked to 105 degrees and I had not slept in a week. I suffered from anxiety, fear, and depression and had a severe allergic reaction to the medicine administered to me. As a result, extremely graphic and violent hallucinations filled my mind to the point where, although I was just lying in bed, I was sweating profusely from the horrific images in my mind. In fact, my heart was beating so fast that the doctors told my family that if they could not slow it down, I would have a heart attack and die. I left the hospital 6 weeks after arriving there, but not before a number of complicated surgeries to rebuild my mouth and face, extracting bones from my legs to reconstruct my jaws and to lay the foundation for many more surgeries over the next 5 years. In fact, my first surgery was almost 19 hours long. At this point, I've had over 24 surgeries. As an outpatient, I was attached to a feeding tube for several months and required 24/7 nursing. I spent 8 months on convalescent leave following a general cycle of surgery, pain medication, and recovery period over and over. And although I was originally a patient in a military hospital, I've received the vast majority of my care from civilian healthcare providers. Like many returning from Iraq and Afghanistan, I continue to have issues with post-traumatic stress. These episodes can range from nightmares to mental reenactments of my injury, to inexplicable waves of emotion. Although PTS is perfectly normal after going to war, in this country and within the Department of Defense, there still exists a certain stigma associated with it. I truly believe that a sign of real strength is not to tough it out and pretend that the condition does not exist, but to be upfront about it and get the help that I need. I went to counseling for 18 months for PTS. which helped me identify my triggers and how to calm down when necessary. I strongly encourage anyone who's facing any sort of behavioral health issue to seek the counseling. It made a huge difference in my life. But I'm only one wounded warrior, and there are over 50,000 just like me from the wars in Iraq and Afghanistan alone. That means over 50,000 families uprooted with lives turned upside down, and more than 50,000 warriors who will spend years reintegrating back into society and adapting to their new normal. These are the obviously wounded. They are missing limbs, are blind, have newly deformed heads, or are now committed to a life in a wheelchair. Hundreds of thousands of other service members suffer from the invisible wounds as they continue to fight the enemies that rage inside their minds. Not only does this pain affect the injured, but their caregivers as well. Caregivers go through so much, including the emotional pain of seeing their loved one injured, going through recovery, and then facing lifelong challenges from physical and invisible wounds. My wife, Dahlia, has been my caregiver since day one, and she was the biggest part of my successful recovery. As civilian healthcare providers, you are uniquely positioned to support veterans and their caregivers. Some of us are surviving injuries that would have killed us in earlier wars, but our recoveries can be very complicated and take a long time. The earlier you can develop a personal relationship with us, where we feel comfortable with you and confident in our recoveries, the better for all of us. My new normal is a testament to that, and I hope that my story, today's webinar, and the entire Joining Forces Wellness Week series inspires you to develop and refine your skills and cultural competency necessary to provide effective pain management for the military connected. Thank you for attending today's presentation.
Quite a story, right? Justin is an amazing person, and this is one story. There are many stories. And to our earlier themes this morning, it's hugely important to understand these particular stories. Now, turning to an effort at a medical school, I'd like to offer an impact perspective based on a medical educator's viewpoint. In addition to what you see on the monitor, Dr. Holtz, who couldn't be here with us today, is prior service and understands the issues of the military connected. And so we're going to talk a little bit about his work on asking the question and documenting this in an EMR. Dr. Holtz served on our Joining Forces Wellness Week Advisory Committee, and that's how we met. He will say that it's important to, Henry came to me right after the first Wellness Week and said, you know, this is great. It's a great program, great effort here, but there's another real need that we can work on together. Providers aren't trained to ask the question about military service as part of a patient history, and there's no place to document even if you know to ask. My reaction to Henry was, great, let's work on this together, because you need to know what to do with the answer if you ask the question. So we did. We went to a resource developed by the Office of Academic Affiliations at the VA. They give all of their learners, those 22,000 students and 37,000 residents, these pocket cards that come through their health system. And they prompt certain questions and information to elicit from patients. We took this pocket card and adapted it to our work. We came up with one key question. Did you or a loved one serve in the military? And this should be asked of all patients in any type of encounter. If the answer is no, you move on. It's a simple, quick, easy thing to do. If the answer is yes, there are 4 basic follow-up questions that will help you gather more information about the person you're getting ready to help. This may support a more effective diagnosis and treatment by providing you more complete information. The goal is to ask as few questions as possible of all patients that will accomplish understanding the impact of current or past service on current health issues, potential challenges, potential changes to the patient's prevention plan, and referrals to other physicians and resources as warranted by their story. So this is the way that Henry found some of these could be gathered at his health system. He'll tell you that he really sees this as a national priority, with interoperability as a key feature in the continuity of care. And interoperability has been key. When we set about this work, the default in 2 major products that are on the market for EMRs was to have the question about military service turned off as the default. So we worked to turn it on, and it was quite a challenge. We got into this loop of who was supposed to ask about having the question turned on at one point. But Henry did it. All 6 affiliates at Tufts got their vendors on board, and now providers are prompted to ask consistently across all of their health system, hospitals, and clinics. Henry will make these 2 recommendations. If you encountered him, he would say, the question of military service should be made part of meaningful use criteria in all civilian EHRs. That's critical. And providers must learn to ask the question, be aware of what to do with the answers, and document. This means that military health issues must be covered with learners somehow. And so I'm going to turn to Steve because, learners never want to know what's on the test. Right, Steve?
Thank you. Well, I'm going to provide you with the perspective of National Board of Medical Examiners, which is where I work. We'd be naive to believe that USMLE does not drive curriculum. In fact, that is one of the reasons why we were invited to participate in joining forces. An example of this impact is heart sounds. About 8 or 9 years ago, we actually put recorded heart sounds on the examination. The examinees would use headphones to listen, and when we actually compared the questions with actual heart sounds to those with text descriptions of heart sounds, the actual heart sounds were 10 to 12% harder on step 2 and 20 to 25% more difficult on step 1. After 7 years, those differences went away. The students were learning the heart sounds. We knew that if we were to make an impact regarding joining forces, we would have to develop a great number of items in actually a fairly short time frame. Our usual, when there's a new topic area, our usual way of generating items is to one committee, assign a few questions to each one of the committee members. That would take forever to make an impact in something like this. Additionally, we found that this required a different expertise than what we had on our committees, and so we had to look outside for that expertise. Recruiting, the goal for us was to have 12 item writers on 4 different task forces, so that we could generate somewhere between 1,200 and 1,400 items, and would give us about 600 live items. The VA awarded the NBME a sole service contract to develop this content, and we knew recruiting expertise was going to be difficult or a challenge, and we identified physicians through the 3 branches of service, through the representatives from the Air Force, the Army, and the Navy on the board of the National Board of Medical Examiners, and VA physicians through Karen Saunders, who is the Deputy Chief Academic Affiliations Officer. The logistics of training our item writers was going to be another challenge. For instance, normally we have probably 2 to 3 new committee members that come on board to any one of our 17 test writing committees. We would have a workshop, 3 workshops throughout the year, 1.5 days long. But with the group of physicians from the military as well as the VA, we could not go that route. The physicians in the military were sometimes deployed, and finding a day in which they all could come to Philadelphia was going to be next to impossible. So we developed a web-based workshop and delivered it about 20 different times. We also worked with USMLE governance as we developed the content and got the items on the live examinations. Within the single content outline, we identified about 34 topics that were appropriate for joining forces, including anxiety disorders, which included PTSD, substance use disorders, spinal cord disorders, including transection, ear disorders, including hearing loss, as well as multi-system infectious diseases, including acute fever, brucellosis, leishmaniasis, and then also multi-system toxins and environmental extremes, including heat illness, Gulf War syndrome, and radiation exposure. To date, we have 26 different physicians that have joined us in writing questions. 14 of those from the VA, 4 from the Air Force, 3 from the Navy, and 3 from the Army. One individual, an additional person who was from private practice, who had been in the Navy for 18 years, and then somebody, a University of Pennsylvania faculty member who during Vietnam was an Army Ranger. We convened 5 task forces between December 2014 and December 2016. And we have actually one additional task force planned this next winter, so we can get to our goal of 12 to 1,400 questions. So the questions that are written for joining forces or related to joining forces topics for USMLE undergo the usual process that all items go through. Task force members write the questions. They come to a meeting. Each committee member that wrote a question will read their questions aloud. Those questions will either get the thumbs up, thumbs down, or get modified. Those questions that were either accepted or modified then are pre-tested on one of the examinations. The questions that have appropriate statistics will then undergo another review by what's called an interdisciplinary review committee. The IRC is basically making a judgment whether the question is appropriate for the general medical licensing examination. Those questions, if accepted, then make it to the live pool for USMLE, and then for the next administration or next build for one of the examinations, we have constraints and a computer, basically software, that will pull questions in based on the constraints.
So if we think about this national initiative and reflecting on what happened with it, a framework emerged which could be useful for other initiatives coming down the pike. So there was a national need and awareness raising that was identified external to our community. It actually came from other sources. For us, it was the White House. For USMLE, it was the VA and some other forces. There was a launch in our community of our involvement, a needs assessment of what was going on as a baseline, and then where we are headed with that, because we found gaps, and so developed local and national interventions to address the gaps. Now, the outcomes is still a sticking point in this model, and I think, Steve doesn't have test question performance yet, and we know how many people attended our webinars. Last year, we reached 2,000 people with the webinar series. We know how well they were rated. We know what topics resonated, but we don't know what providers are changing behavior to routinely ask the question about military service. So I think outcomes is still a sticking point for all of us on this, but if we work toward taking better care of the military connected, we will surely get there. So at this point, I'm going to turn it over to Steve, who's going to facilitate our discussion.
Okay. Well, we will be happy to entertain any questions that the audience might have.
There's one. We have mics coming around the room, if you'll just...
So as a country of immigrants, there are people who live here now who are veterans, survivors of other militaries, and suffer from similar problems. And I wonder if there's room. I don't think that the VA can fund these things, but I think it's important for them too to be included, certainly by their physicians in interviews. What is there any? Have they been taken into account at all?
Actually, I believe the impact of getting this information and education out to the physicians in the community and the trainees who are going to be physicians in the community will help those individuals, in the long run, whether they served in one of the U.S. services or served in the military for another country.
It's a great question, and that's why we say ask the question of all of your patients. Don't just go by what you see coming in the door, because you never know who might have served, or to your point, where they might have served.
Hi. Since we know that there's such a high comorbidity between physical ailments and distress and PTSD or depression or suicidality, that when someone walks in to see a medical provider, we know that there's often an overlay of a mental health issue. What steps are being taken to improve the collaboration between the medical community and the mental health treatment services to really make that a more holistic, client-centered treatment program?
Do you have some thoughts about that one?
Well, I do know that the joining forces had close to 35 different organizations, probably encompassing probably 8 or 10 different disciplines, whether it was social services, physical therapy, physicians. It covered pretty much the whole spectrum. So I do know there were a lot of different groups involved with the initiative when it came out. Anita, do you have anything to?
Yes, that's a great point. It's been a cross-collaborative issue initiative from the beginning. I think it speaks to sort of the way that healthcare is moving, and we're all part of a team, and we operate in these team-based environments. And so the whole team has to know. That's why it's so important to document, I think Henry would tell you, because someone else can look at the chart and pick up for what they can help the patient with.
Hi, I was just wondering if you were incorporating the families, the questions that the doctor should ask if any of their families have been in the military.
Yes, that's part of the question. Have you or a loved one served? And the loved one could be anyone to you, whomever you count as a family person. So that was a huge part of this from the beginning.
And I was also just wondering, and I think maybe I should know this, but I don't. Is there special training for the doctors in the VA hospitals, or do they get the same medical training that?
I don't know about the physicians once they're onboarded at the VA. For students and residents, there is some education with the pocket card, but probably not enough, from my view.
Yep. Thank you.
Mm-hmm. Well, Steve, as we were preparing for this presentation, one of the things that came out was our passion for this topic. And I'm wondering if you would like to say a little bit about what drew you to this initiative and to your work on it.
Well, part of it, I guess, actually has to do with my family. My stepfather served in the Army in World War II in Europe, and my father was a veteran of the Pacific in the Navy. And he spent his last 3 months of life at the VA in Lexington, where I did my residency and was on faculty. So it was, that's probably one of the things that really pulled at me. What about you?
A similar story, except it's my husband, who was a member of the military during the first Gulf War. He was a combat engineer with the Army and was deployed my senior year in college. And so I was trying to finish school while he was away fighting a war, and was actually one of those family members who did not get asked about stress-related issues in an encounter with a physician when I probably should have been. And so that's why the family piece has been so important all along the way to our Wellness Week program, because I get it. And so he got back. Luckily, he was fine. But seeing and I think his generation is cared for a little bit better than previous generations. But knowing that any of our children could serve, I certainly wanted them to receive better care than he's gotten over the years. And my nephew is in right now, so another compelling reason for him and his family. It's personal to us and really important to us.
And we do know that deployment is very stressful on the family. In fact, I guess one, not so good statistic is there's an increase of about 42% in child, maltreatment is how it was termed in a paper I had read when there's a family member deployed.
I too was a military spouse, and I think that sometimes there's not a great focus. I led the family readiness group when my husband was deployed to Afghanistan, and the husbands are over there and wives are over there fighting, and when a soldier dies because of a bomb blows and a roadside bomb blows, they're dealing with the death over there, but the family members at home, we're going to the chaplain, and we're going to the services for the loved ones that, for the family members that were left behind, and just watching the loved ones suffer. And they would have a big picture of the military member up on the altar, and then going through the service and videotaping it for the little kids that were there that lost their father, because it was the wishes of the widow left behind that they wanted to show the video to the family, to their sons or daughter when they grew up. So I think thinking about the families, what they go through, I saw it firsthand, and it was something.
Mm-hmm. Well, thank you for your service.
Anita, how are we going to keep this going?
Well, that's a great question, Steve. And right now, the Center for Deployment Psychology has really stepped up. They've become more than our technical partner. They are going to lead the next year of the Wellness Week series, in all aspects of it, as a bridge year. We are watching what's going on with the Obama and Biden foundations to see where their work leads them. I was at a reception in November at the White House that thanked all of the Joining Forces partners, and the First Lady asked us to continue the work. So how can you say no when the former First Lady, wants you to keep this going? So we are working toward a long-term solution for the Wellness Week program, and we'll see where we go with it. There's several of us kind of hanging on from when it was done by our association, and so we will see where this goes. But we are looking for long-term sustainability for this training, and we plan to get there.
I know we are looking at, we had planned on, having 4 task forces, and I think what we've, where we ended up with would be every other year to every 3 years having a task force come in, plus we are taking some of the really good item writers from the military physicians in VA and putting them on some of our regular test committees, so we can keep new questions coming in all the time on this important topic.
That's great. And I think that's the important point, is this needs to be integrated. This shouldn't be a special thing anymore. It just needs to become part of what we do, and seeing these patients as another aspect of patient diversity. Should we close now? So in closing, we just want to offer some brief perspectives and lessons learned that we'd like to share. So from the association perspective, we leveraged our convening strength to raise awareness and compel action in our community. Authenticity was really key in all of this. This was not just a PR effort for us. This was more than a PR effort. And it takes time to build awareness and participation. We went from 100 to 2,000, and we feel like we're just getting there with this program. From a medical educator perspective, I'll summarize for Henry, and that's military is another aspect of patient diversity. Ask the question about military service, know what to do with the answer, and then document for you and your team.
I'm going to give you the patient perspective as well as the assessor, or as Graham said this morning, the regulator. The patient part of it is, I'm sure I can't do it justice, but patients want somebody to understand them for who they are and not just a medical illness or a disease. And also the strength that they bring to their care. Also, they're looking for somebody who will attend not only to the patient but also the caregiver and the patient's family, and also someone who will use their orientation to help them heal. From an assessor point of view, I have just been so moved by the physicians that we have brought on board to help us with this, their dedication. One individual was deployed on the U.S. SN Comfort ship, and he was writing his questions while he was basically on the ship. Had trouble getting them to us, but once he got someplace where he could send them to us, he was able to. Some of the committee members or task force members actually had to take vacation time. And the staff that work for me have been just great in helping keep this moving. And the NBME is looking to use this as a model in the future as we add content for other populations.
Well, we thank you for being in our audience today to hear about this important initiative. We hope that you'll take something back and make a change at your institution or your organization. And if you have served or are currently serving, or you're the loved one of a service member, thank you.
Yes, thank you.